Okay. I think 46
Yeah.
some people, 46 are there. I just want to make sure my sound is clear. I am visible. Uh, Echo is there.
Yes, yes.
Okay, let's see
There's no
how.
echo. You can hear a echo, is it?
No, as such, like some participant had just told, like it's audible according to them.
Yeah,
I'm
yeah.
not
You are
sure.
audible and you are visible also.
Okay, okay. I cannot see anything, any of this actually. I'm
You
kind of
cannot see. Are you in Zoom?
fine. It's
Hello.
okay. Yeah, Mansiji. So I think ample numbers have arrived, like nearly 49. Uh,
Okay. All right. So you can start sharing your screen and you can begin then.
okay. It's all right.
To the audience or the students, I'd like to announce that uh, Dr. Subir is going to run a few polls, questions. I guess you all are aware of the pattern. But for you to be able to answer these questions or these polls, you will have to have the Zoom app either in your laptop or even on your phone in case you're accessing the webinar from the phone. You will have to have the app installed with you. Only then you will be able to answer the polls.
That portion thing is not coming in seconds.
You will have to go to advanced.
I went there, but the screen is changing.
You can minimize this or you can close it. You can close this. You can close the browser.
No, it's okay. I hope it's coming. Yeah, now I think everything's clear.
Yes,
Which I'm supposed to show the participants
only
only.
the slide.
Yeah,
Yes,
yeah.
I can see only the slide.
Okay.
Can you see? Are you getting the option of polls?
Cool. Yeah, I'm getting. Yeah, I think
Yeah,
we'll
and you are getting the questions over there. And
polling. I'll
sorry,
just.
your
Yeah, it's coming actually.
okay, perfect. All right.
Let's see. Okay.
Yes.
So I think we'll begin the session without any delay. Hi all to all my.
Sure, sure. Go ahead.
Yeah. Hi all to all the students who have been with me for long. I think it has been a long journey, about 5 months with you all. And at the outset, I would like to thank Dr. Sudhir Kothari sir, uh, who is and the fine team for giving me this opportunity. And you very few will be knowing about fine because it is actually a very extensive teaching program which has been conducted among DM neurology students as well as the DM neurology consultants as such. And it is actually conducting worldwide seminars, webinars, etc. So getting associated with Spine is a big achievement, like a big thing for me. And through me, actually, you are getting into a forum of very great neurologists as such. So after this, like this is actually a new venture where the Fine is reaching out to the MD students who are aspiring to be future neurologists. And the term neurophilia I have put just because of the reason that there was a term like neurophobia is a term which was there previously described by Josephovic in 1994. That is actually a fear of neurology, which is perceived among the students as well as the maybe physicians also, because of the lack of bit of concept about neurology and making it into the practical application of treating patients. So in 2014, I would like to remind that 2014, Dr. Satish Kadrilkar sir had done a study on this and had said that it is actually there, especially in Mumbai. The study was done in Mumbai. So with this, I will just try to inform you what this is planned to be, like how it is like planned to be, and what is our aims with this series, what we intend to do with this series. So the main aim is actually to generate neurophilia among postgraduates. So as I said, Satish sir had done the study. I just tried to redo the study this year, and the study is going on. But I think that's every aspect of that study shows that neurophobia is going away and neurophilia is coming in, and this will definitely help you in your due process. So our venture is to generate neurophilia among the postgraduate students, and in the last 5 months being with you all, I have found out that the you have all the necessary materials to read and study, but the thing is that there is some lack of motivation or maybe proper guidance. And since we have ample time till the next NEET exam, I think 8 months is there. So we'll have a fun learning rather than a stressful learning, and also to know that to kindle interest in reading the standard textbook of neurology. That is the basic thing, because all the exams now are following some basic textbook, especially the Bible of Medicine, that is Harrison, as well as Bradley or Adams, to crack into the top 100 or to get into the institute exam. So making reading this textbook is should be a habit, and will tell you which portions to be emphasized while reading for the exam. And also, you must have just noted that there is a change in the recent trends in the neurology exam patterns, because they are asking more of one-worders, direct questions from the textbooks, and also the repeat questions are like a bit going low. And as you have noticed that recently, the pediatric neurology has become a big part of the entrance questions. And our aim would be NEET as well as to crack into the in all the institute exams, especially the NIMHANS, AIMS, PGI, JIPMER, and Chitra. And as you know, this is a vast ocean of neurology, and to pick up pearls of wisdom is very difficult. That is to emphasize on the important points. And we plan to give it to you some points which you must have already learned, but you failed to get the aspects of it or the concepts from it. And as you know, there are living legends and great teachers in neurology. Some maybe have got, some may have been lucky to be with them, but some are not. Like this, I would say is Dr. Baldev Singh, who is otherwise known as Papa Neuron or the Father Neuron, a great neurologist. And so many neurologists are there who is following his path, teaching, their spending their lives in teaching as well as treating. And with this forum, we will get to know about the inputs they have to give, especially the experts and the living legends from the field of neurology. And with this, we will try to reduce the communication gap between the practicing and, or I will say that teachers in neurology and the aspiring neurologists. So this would be the aim of this venture. Hope and pray that this is a successful venture. I alone won't be continuing. Lots of people will be joining in, because I see a lot of interested neurologists willing to teach the upcoming MD people or MD aspirants, as well as those who are aspiring to be neurologists. So to fall in love with neurology, definitely you need to read the books. And some books are there, but we cannot all read this because we have lack of time. We have to prepare for the exam. So books, by what I mean by books is actually this basic book of Harrison, 20th edition. It's better to know each word from the neurology part of this textbook. And as I said, to get a higher information, to upgrade yourself to the top 100, to get into the institutes, definitely you have to study certain parts of Bradley neurology. And I should warn you that Bradley, actually new editions come by about 4 to 5 years. And new edition is about to be delivered or published or given to you by about March. So you have to wait till then before buying a hard copy. Till then you can go on with the PDF version of the previous Bradley. So with this, I'll straight away go to the questions. So this is actually not a capsule where all topics would be crammed and told to you in a capsule form, spoon feeding, stuff won't be given. But what we plan to do is to make you read the textbook and have an MCQ annotation of the textbook and make it fun while learning all the points. So I have made my slides a bit more colorful for this aspect. And I would start by asking you this question. So, sorry. So,
Dr. Ahmad,
yeah, starting the poll.
yes, we also have somebody who has raised their hand. Do you want to sort of know what they want to say?
Um,
Two
yeah,
people
sure.
have raised their hands now.
Yeah, sure, sure. Is it something
Okay.
wrong with the voice?
My voice is breaking.
No, you not your voice. Like people have raised the voice to have some. Are they having some problems with listening or like viewing stuff?
Uh, let's see. 1 second.
Okay.
In if you want to ask something which is clinical or related to the talk, we would request you to raise hand. In case if there is any technical thing that you want to say or tell us, I would request you all to please put it in the chat.
Yeah, I would have liked to have this as an interactive session, but I don't think because we have ample time for that. Maybe some questions we can keep it in the end. Till then, I think we'll just go with the questions because polls are there, so that will
Polls.
be
Sure,
tough
sure,
question.
sure.
I'm not sure
Go
what
ahead.
I think they can put up in the chat actually, so that they'll.
They have lowered their hands. They have lowered their hands. So
Okay. Okay, maybe doubts they can also send me through message also. Don't worry regarding that. So this
yes.
is the first question. Which one of the following parts of the brain is associated with control of visual reflexes? Are you seeing the screen? Uh, are you able to answer? I think they are answering.
Yes. Okay.
Okay, so that would be enough. So most of have we have a mixed answer. So this one most have answered, about 50% of them have answered it as mesencephalon. I'll request you all to attend because once you attend only you will know that you have gone wrong somewhere. And this is not an exam. So make mistakes here, correct it in your exam, and that will be the best way to go. So don't be hesitant and like stay back, sit back, and be actively participating. And that's why this polls have been kept. So that is true. Most have answered it as mesencephalon. So let's see what the answer is. So seeing this question, we know that they are asking about visual reflexes, which are and their controls. So visual reflexes in a go, like it's actually the just the consensual light reflex and the consensual reflex. And pathway, all are familiar with the visual pathway and as well as the reflex pathway. And if you see the MCQ options, they have not straight away given you the parts of the brain like cerebrum, midbrain, pons, or medulla. They have tried to emphasize or accommodate the embryology part. So learning neurology is to study some parts from the neuroembryology, neuroanatomy also is to be studied. So I'll just brief you that in embryology, first thing is to appear as a neural plate for the nervous system development. So it occurs by about 16 days that the neural plate develops, and by about 22 days, the neural tube develops. And we need to be aware of some defects here in the neural tube. And the neural tube actually closes from behind at the region of medulla first at about 22 days. And anterior pore is closed, that is the anterior portion is closed at about 25 days. And by about end of the fourth week, the posterior neuropore, that is a caudal region, basically our lumbosacral region gets closed by about 28 days. So 25 anterior, 28 posterior, and we get the neural tube. So this is actually the neurulation part of the embryogenesis. And after this embryogenesis, we know that folds are formed within the brain. Basically, the three primary brain vesicles, the prosen, meson, and the rhombencephalon. Further, they divide to form the cerebrum. Diencephalon forms the thalamus, hypothalamus, and epithalamus. And metencephalon forms the pons cerebellum. And myelin to the medulla. So all these could be asked in your exam as questions. For example, I'll tell you which where does the cerebellum arise from, or which is the 5-week embryos part uh, uh, of the cerebellum. All the same options will be given to you. You shouldn't get confused that it is whether meson, meton, or myelin. And as you know, visual pathway, everybody is very clear of it. And the visual pathway starts from the retina to the optic nerve, and it has decussation of the pretectal nucleus, the pretectal region. It goes to both sides of through the Edinger-Westphal nucleus, comes back as short ciliary nerves, causing the contraction of the pupils to have the light reflex, both direct and concentric. So our question was, what is the part of the brain which is controlling the visual reflex? So you have, most of them have answered right. It is actually midbrain, and midbrain is derived from mesencephalon. So similarly, I would like to ask the second question. There is actually second question. Mansiji, like next question, rather than relaunching the poll, how, yeah, okay, I got it. So second question, can you see the questions? Yeah, try to answer this question. So which part of this, which of the following is not included in the part of a pupillary reflex pathway? And by the time you have seen the visual pathway, you have studied the brain embryology in brief. And now I think most of them will not make mistake in this. So as we know, the lateral geniculate body doesn't get is not included within the visual in the pupillary reflex pathway. It's continuous as a visual pathway, and so that is the reason why I told you that you have to have a associative learning. So we learn the visual pathway, but if you are not thorough, we may get confused in this pathway parts. And so, and the next question would be, actually lateral geniculate body, which is not the part of the pupillary reflex. It's the part of the visual pathway. And so lateral geniculate body is a derivative of which part actually? So we are learning in steps that how the embryology and the functionality is related to. I thought most of you would make mistake because you all have all been thorough with the topic. Some mistakes are there. 20% are getting it wrong, but 60, that's a good percentage, are getting it right. So lateral geniculate body is not a part of mesencephalon. In a one go, you may think that it comes in the visual pathway, and so it should be the midbrain, but it's not. It's actually, lateral geniculate body is a part of thalamus. So if you see, lateral geniculate body and medial geniculate body are parts of thalamus. And medial geniculate body is concerned with hearing, and lateral geniculate body is concerned with vision. And that is the reason. And one more question I'll ask. This is an EEG of a patient in the posterior segment. And what do you think is the wave we see here? Because it's an awake but resting and eyes closed patient. So what will be the waves? I know most of you had answered it right. This is actually the alpha waves. Why did I ask this, put this point here is because you should know that in the EEG, the alpha waves are produced basically from thalamus, especially from the lateral geniculate nucleus. And for the question, alpha waves were the first waves to be described, and it was otherwise known as the Berger waves because Hans Berger was who invented EEG in 1929, and first waves he described was the alpha waves. He also described the beta waves. So I didn't mean to upset you because this much of learning, this much of this associated learning is actually a need of the hour. Because if you learn by paired association, every time you see a question, you relate between the two parts. Because about 20% of the questions, less than 20% are only repeats in the exams. And about 30 to 40% would be incoming questions coming in and around the repeats. So that is the importance of this learning. And again, emphasizing the fact that you have to learn Harrison, Neurology, Bradley. And before starting a new subject or starting fresh for the next exam, I advise you that from MBBS period and MD period, you have been studying neurology in portions. So revise what all you have written, scribbled notes or made notes of, and the textbook you have followed then. And then we'll form a strong basement and build on it. So with this, I like to go to the topic proper. This was just an intro for our venture, what we plan to do. And so next, today's topic is actually stroke. And the portions which are covered in Harrison is actually 3 chapters, and Bradley are 4 chapters. You have to know, or you have to study basically Harrison 3 chapters. In due course of time, we will see which all portions to be emphasized in the Bradley. So first question in stroke would be, how many Brodmann's area are there in the brain? I think I forgot for the pools. Wait a minute. Okay. How many Brodmann's area are there in the brain? Just give a guess. If you don't know, then only will know. And if definitely it's not 36. You know, Broca's area is 44. So definitely answer is not 36. So definitely more than that. Okay. So actually, there are 52 Brodmann's area. These are actually cyto-architectural areas within the brain, which corresponds to the functionality of the brain. So this was the German anatomist who described the Brodmann's areas. And as you know, from this, you must be knowing all the other areas, like primary sensory area is the area concerned with primary, that is area 312 is the primary sensory area. You can see here. And area 4 is the primary motor area. And 8 just looks like eyes. So it is actually the frontal eye field area. And I always remember Broca's area is actually 44, and half of it is actually the Wernicke's area. And if you see here, this region, anterior to the area of the eye, a 9, 10, and 46 actually is the dorsolateral prefrontal cortex. So while studying cognition, you may come to know that actually in the coronal section, if you see this is actually the dorsolateral prefrontal cortex. And this corresponds to area 9, 10, and 46. And this is associated with executive function. If you can see here, executive function. And medial side is actually this area, which is covered by the area 24. That is the cingulate sulcus region. This is associated with M for medial motivation. So M for motivation. If somebody has affection in this area, they will be apathetic. And this is the orbitofrontal area. Apart from this, other areas are the calcarine sulcus, which contains the visual areas. And some areas you have to know is Heschel's gyrus, that is area 41 and 42. So the area 41 and 42 is concerned with auditory cortex, that is otherwise the Heschel's gyrus. So these are some areas in Brodmann's which we need to know, and I have just summarized it for you. The angular gyrus is the area which is concerned with alexia and agraphia. And if you know that, if area 39 and 40 are affected, that results in what is called as the Gertzmann syndrome. And primary olfactory cortex is actually area 34. If I'll just show you that. So this is area 34. This is olfactory cortex, and uncus is there. And this area 37, is actually fusiform gyrus, which is associated with face recognition. So I have just summarized. You needn't take a screenshot or all, because this video will be available. So just summarizing the important areas for this. And with the Brodmann's area, I think you could relate to the functionality as well as the specific areas, anatomical relation between the parts of the brain. And for stroke, what happens is that some functions are lost due to acute shortage of blood supply or due to bleeding within the parts of the brain. So circulation within the brain is divided into anterior circulation and the posterior circulation. That's an extensive, vast topic. I'll just cover some areas which you may miss to read, or you may miss to focus on while studying these areas. So this is a CT of a patient who presented with left-sided weakness and left-sided facial weakness, as well as hemicoria. So you saw the CT, I guess. So let's take a poll of this. Number 4. Sorry. So what do you think the answer was? Like, if you see this question, so you saw the CT, and now try to answer this question. So I have noted in all the questions that usually the options in the answer will be not straightforward. Just not, they won't be asking like MCA, PCA, ICA, and others, but they will be asking some eponymous arteries or eponymous functional eponyms would be there in the answers. So in this question, the CT you had seen, and he had left arm weakness, face weakness, and hemicoria. So what do you think the area is affected? Which is the area affected? You must have heard of artery of Percheron, which is very famous. Then there is a recurrent artery of Hubner, anterior carotid artery, artery of Brodmann. 12% have answered as artery of Brodmann. It has nothing to do with the brain. It is an artery in the abdomen. I just put it. So most of them have got it correct. So I'd like to say artery of Percheron is an artery which arises from the posterior cerebral artery. It's a single artery which tries to supply the thalamus as well as the medial part of midbrain. And artery of Percheron infarct will look like this. There will be hyperintensity in both the thalamus, as you see. And if you see the MRI, you can see that the midbrain is affected, medial midbrain, as well as both the thalamus is affected. So patient will be stuporous with decreased orientation or in a coma-like stage because of artery of Percheron involvement, if it's extensive. And as you know, our case is actually involving the basal ganglia region. If you had noted the CT, we had the infliction in this area. And this is actually a recurrent artery of Hubner territory. So recurrent of artery of Hubner, the questions usually asked would be, where does it arise from? Whether it's from ACA, ICA, PCA, or MCA. Actually, recurrent artery of Hubner is a branch of ACA. This is the typical infarct you see in the recurrent artery. This actually is pathognomic of recurrent artery of Hubner. So it's actually a branch of ACA. That is the A1 section. A1 is the section until the ACA develops the ACOM, that is the communicating artery. So these are actually medial striate arteries, and one of the biggest medial striate artery is the artery of Hubner, which supplies the basal ganglia part of the brain. And that is why we get hemicoria. Because of mild involvement of the internal capsule, we get the weakness of the corresponding area. So our answer is actually recurrent artery of Hubner. So another artery which is notorious to be like usually asked in the questions is anterior carotid artery. So if I if you try to answer this question. So what is the usual presentation of an anterior carotid artery syndrome, and which is usually not seen? Most of them have given the correct answer. So it's actually, you think it's left neglect. That actually you can see that if left side is affected, the right side should be having some symptoms. So that is the answer. So recurrent artery, this anterior carotid artery has a symptom triad of contralateral hemiplegia, contralateral hemianesthesia, and contralateral hemianopia. So you must have learned that hemianopia usually settles, we see in the posterior circulation, especially in the occipital lobe infarcts. But why does this occurs in an anterior circulation problem? That is hemianopia. So usual triad is contralateral hemiplegia, hemianesthesia, and hemianopia. But you should know that apart from that, there is a neglect syndrome which arises if the lesion is right-sided. And if the lesion is left-sided, as in our patient, if we see, there should be actually a speech problem. There is some kind of aphasia which sets in due to the same disease, infarction. So this is the area which is affected. You can see this is the posterior limb of internal capsule. That is otherwise called PLIC area, PLIC, posterior limb of internal capsule, and the associated areas getting affected, resulting in the so as you see, you have hemiplegia due to the posterior limb of internal capsule affection, hemianesthesia due to the thalamic affection, and lateral geniculate body, which is, as you had initially seen, is present here. And if it does get affected, you get the hemianopia because it is concerned with the visual pathway. So that was regarding anterior circulation. So you need to study the different parts of the anterior circulation, and I just emphasize that these two arteries. And if I put a question, just see this question. First, I'll give you simple options. So this is actually a 53-year-old female who presented with left-sided hemiparesis, proprioceptive loss on the left side, and the tongue deviation is there on the right side. I think you can see the options. Yes. So most of them have answered it correct. So there is no, this is actually kind of an MBBS question. So it's actually medulla. So how did you come to this answer? But if I give a second option to the same thing, same question, if I give you a second, options are different, like this. What would you be? What would be your answer? Actually? So you can start answering. The 53-year-old female presenting with this. Oh, I think 100% of all answering are getting it correct because you are thorough with the topic. Well and good. Okay. So this was the first options, and with this I'll try to simplify the posterior circulation for you. Are you aware of this man? This is actually Peter Gates. He came up with an easy way to or simplified way to identify the brainstem syndromes in his article based on the rule of 4. And the rule of 4 actually says that 4 structures are midline. That is, M midline are motor structures which are medially placed. S are the side structures or lateral, which are the ones which are laterally placed. And the nuclei, all the divisors of 12, that is 3, 4, 6, and 12 are medially placed, and the rest are laterally placed. And as you know, medulla has 4 nuclei, that 8 to 12. Pons has 7 to means 5 to 8, and the rest 4 are above pons. That is 2 in the midbrain, and first and second is not included. So this is actually the medial structures: the motor nuclei, medial longitudinal fasciculus, medial lemniscus, and the pyramidal pathway. The lateral structures are the spinocerebellar, spinovestibular, spinothalamic, and the sympathetic, which results in the Hono syndrome. So all through the brainstem, this is the usual arrangement. And most of the territorial supply is in a way that either the medial side is affected or the lateral side is affected. So I'll just 4 medial structures, 4 lateral side structures, 4 medial motor nuclei, the cranial nuclei 9 to 12, pontine nuclei, and these things are known to you. Actually, motor cortical spinal tract when affected causes weakness. Lemniscus causes proprioceptive loss. Medial longitudinal fasciculus causes ophthalmoplegia, and the individual motor nuclei of the cranial nerves causes in corresponding symptoms. Similarly, occurs in the spinal pathways, that is the side pathways. And so our question was, the patient was having left-sided weakness. So the motor part is affected. It's the medial part, and it is on the right side. Proprioceptive loss over the left side. So again, the medial lemniscus, which is again medially placed, and the cranial nerve 12 is affected, which is medulla. So this is actually the medial medullary syndrome, which we had seen in the patient, in a patient with left-sided symptoms. So similarly, if you try to answer this question, can can solve this. So try to answer this. So this is actually a patient presenting with left-sided meiosis, anhydrosis ptosis, left-sided ataxia, and uvula deviated to the right. So where would you localize? So I think this is a fairly simple question. Yes, actually it's the lateral medullary syndrome. So how do you derive to the answer? Because it's a simple question for you. So the sympathetic tract was affected in the left, as seen by all the Horner syndrome features. Spinocerebellar on the left, causing ataxia. And you know the 10th cranial nerve was affected because uvula was deviated. That shows that it is the lateral medullary syndrome. Lateral medullary syndrome actually is not a straightforward syndrome. It has got multiple other features apart from this usual affliction. So if the patient develops dysarthria, dysphagia, and hoarseness of voice, it suggests that some nucleus ambiguous is affected. Sometimes the facial nerve can also be affected because of the genuflex fibers from the facial nerve. Also, you should know that there is a number of hiccups occurring suddenly is otherwise called as a singultus. It is also occurring due to the middle medullary affection. And nucleus tractus solitaris can get affected in this lateral medullary syndrome based on the extent of the lesion. That results in the loss of taste in such patients. So that is regarding lateral medullary syndrome. So this is the medial part and this is the lateral part. So this question with I think we'll go with the poll. So this is a 45-year-old male came with left-sided weakness, right eye deviates medially, with right-sided facial weakness. So sit and think and try to answer based on the what we studied in the rule of Gate, like rule of 4 by Gates. So you must have all answered. Okay. We share the results. Okay. Most of you have answered as a medial pontine syndrome. Okay. So what we have here is actually left-sided weakness, which suggests that there is right-sided corticospinal tract involvement, which is the medial tract and right eye deviates medially. So right eye deviating medially suggests that there is a lateral rectus affection over the right side. So right lateral rectus is affected. And right facial weakness also suggests that the seventh nerve is affected. So in this patient, actually we have the seventh nerve affection, the sixth nerve affection, as well as the corticospinal tract, which is present medially, which is getting affected. So these are the areas getting affected, and hence it's actually a medial pontine structure affecting. So it is, as you rightly said, it is a medial pontine infarct. So same way, we'll try to answer. I think polling is taking more time, and you all are answering it well. So whether we should continue with the poll. So this is actually a 60-year-old male presented with left-sided ipsilateral ophthalmoplegia. Pupillary reflex is lost, and there is paralysis of the right arm and leg. So where do you localize? Okay. Most of you answered as a medial midbrain syndrome. So let's go into the topic. So structures affected would be the third nerve on the left. The third nerve again, pupillary reflex is affected. So third again on the left. And the motor tract is affected, which is medially placed on the left. So it is actually a medial midbrain syndrome. And since you know, these syndromes are like midbrain syndromes are a bit confusing because we have the Claude syndrome, Benedict syndrome, Weber's syndrome, Northern Angle syndrome, and the Perinaud syndrome. We'll try this because, and as we know, the part of midbrain is actually divided into basal region, which has the corticobulbar and the corticospinal tracts anteriorly. And also we have the tectum and the tegmental part. So smaller part is actually called the tectum, and this part is actually the larger one is called the tegmentum. And anterior to it, we have the basal portion, which has the corticospinal and the corticobulbar tracts. So in Weber's syndrome, what happens is that the third nerve is arising from both sides from the periaqueductal gray. The fascicles come down like this. So in Weber's syndrome, anterior part, that is actually these three are the tegmental syndromes, and these two are the tectal syndromes. And of the tegmental syndromes, Weber syndrome is much placed more anteriorly to affect the basal region in the corticospinal tract. So third nerve is affected, and also the opposite side there is weakness because of the corticospinal tract affection. And Claude is actually proper tegmental syndrome, which affects mainly the red nucleus, and we have the superior cerebellar peduncle here. So that is also affected along with the vesicle. So in which, and less of hemiplegia or weakness because corticospinal tract is not affected. So Claude is actually more posterior or correct midline syndrome, medial syndrome, localized within the tegmentum. And the Benedict's syndrome actually is the combination of Weber and Claude. Benedict's is actually a larger syndrome which encompasses the red nucleus, the corticospinal tract, as well as the superior cerebellar tract. That is superior cerebellar peduncle. So it is actually a combination of all this. And now coming to Northern-Angel syndrome, it is a tectal syndrome, and hence oculomotor palsy, ipsilateral cerebellar ataxia, and usually occurs due to gliomas occurring in the region. And these syndromes are mostly the tegmental syndromes are occurring due to the infarcts. And Perinaud syndrome is a dorsal midbrain syndrome. Posterior part is affected. We have a commissure going, which it is concerned with the upgaze. So there is paralysis of upgaze in case of Perinaud syndrome. And there is light near dissociation, and there is a retraction and convergence retraction nystagmus occurring within the Perinaud. So that is a question asked. Convergent retraction nystagmus is present in which syndrome? And recently in the AIMS, this time the Foville syndrome was asked, which is a caudal tegmental pontine syndrome. And you have to study this separate syndromes occurring. These are the pontine syndromes, and these are the medullary syndromes. As you know, Wallenberg syndrome is otherwise called posterior. It's otherwise called a pica syndrome, but usual artery affection, most common artery affection in a pica Wallenberg syndrome is actually not pica. More than 50% is by the vertebral artery, and the second only comes the pica. And medial medullary syndrome is otherwise called as Digerine syndrome. And if you have a combination of Wallenberg and Digerine, it is otherwise called a hemimedullary syndrome. Both the medial and the lateral medulla is affected. Then it is otherwise called Babinski-Negote syndrome, which will have the combination of both these syndromes. And if there is Wallenberg syndrome just with an addition of ipsilateral hemiplegia, it suggests it is otherwise given a name of Opalski syndrome. So these are the usual midbrain, pons, and the medullary syndromes. So with this, we have just summarized, like anterior circulation is we have completed. Posterior circulation, some questions we have completed. How to come to a diagnosis? What are the different various names? Which are the usually asked questions? And next, we'll go to the topic proper of stroke, in which my question would be, what is the definition of TAA? I can start answering. Oh, some have answered, like it's the first. So you have to be actually seeing the question properly before coming to a diagnosis. I know some have mistakenly given the answer as 1 hour, because that is what the usual thing we find. A TA stroke with features of weakness recurring within 1 hour. But in the definition, actually, it is 24 hours. So stroke. Stop sharing. 24 hours. Okay. And next question is, what is the approximate risk of stroke in a patient? I don't think Paul is needed for this. Presenting with a 76-year-old presenting with atrial fibrillation, hypertension, diabetes, and history of TAA. So in a patient with history of TAA, how do you predict whether the patient will develop a recurrent stroke? So is there any method? Actually, it is through a CHAD-VASc score. You need to know some score. Example, for a patient with atrial fibrillation developing TAA, whether the stroke will occur in the recent 1 year period. The score is actually, previously it was the CHAD-S2 score. Now, extended version of this is their CHAD-VASc score. And also, if there is no atrial fibrillation alone and TAA alone, we use the ABCD2 score. And it could come in your question as how to solve these questions in the MCQ, especially in the exams, it could come. And if you see, our patient is actually 76-year-old who is having hypertension and diabetes mellitus and stroke or previous history of thromboembolism. So the score is roughly around 6, and 6 corresponds to about 9.8. So it's roughly around 10, which was given in the option. So how do you treat these patients? So this patient, you found that the patient was having diabetes, hypertension, a 76-year-old patient, and then what he was having a history of TAA. So how do you treat such a patient? So you can answer. You can try answering, even if you don't know. Just try to answer. So the value is more. So I'll end the poll. We'll go to the answer. Yes, actually, oral anticoagulant is needed for this patient, and it's actually simple, much simpler than you think. If you have a score of 0, it is low risk of stroke, and if 1, it's moderate, and any score above 1 is a high risk. And according to latest guidelines, even you can first line therapy is not just warfarin alone. The newer direct oral anticoagulants like dabigatran, apixaban, etc., edoxaban, and rivaroxaban, etc., can also be given in this patient. So which of the following would not receive a point in this CHAD-S2 VASc score? So you just studied this CHAD-S2 VASc score, and the next question comes to you is actually this question actually, which doesn't have a score. So I hope you all answer it correctly. Okay, try to answer this. We just saw the score, or you must have studied previously. Okay, it's very evident that only female sex is given a score of 1. Male sex is not mentioned in the scoring system at all. So actually, the answer is actually male sex, and most of you have answered it correctly. And as I told you that you can even give direct oral anticoagulants in this patient if it is a non-dramatic AF in such a patient. So this question usually in the institute exam, what is latest will be asked. As you have seen in the recent AIMS exam, you must have seen, I think newer drug for SMA was asked. Similarly, newer drugs actually you have to keep track of. And in case of stroke, I'll ask you this question. So try to answer this question. This was the previous question, question number 15. Okay. So answer this question. So these are some questions which you can answer only if you know. And this will constitute about 10% of your MCQs which are coming in the exams. So as you know, there is negative marking in the exam. Some questions, if you don't know at all, please don't try to guess, because it costs you a negative mark. And if you know answer, and if you can rule out options, negate out the options and come to a conclusion, then it's well and good. Otherwise, these questions are kept to pick out the top people. And be careful. It's better to leave such questions if you don't know rather than to attempt. So most of you have answered as enoxaparin. Okay. So actually the answer is dabigatran. So dabigatran, as this is not a new question, idarucimab. This was a drug. It's a reversal agent which is used to reverse the dabigatran induced side effect, basically bleeding. And the newer one, which was approved in May 2018, was andexanet, and it's a factor 10A recombinant structure, and it reverses rivaroxaban, edoxaban, apixaban, betrixaban, fondaparinux, as well as enoxaparin. It does not reverse dabigatran. And as you know, there is a new agent in pipeline, which I think will get FDA approval soon, and that is siraparantang. Siraparantang. And this is actually, you can consider this as a universal reversal agent because it reverses all this direct oral anticoagulants, low molecular weight heparin, as well as unfractionated heparin. So this you need to know. That is why it is. That is why I told you we have to be aware of the newer, latest developments occurring, especially in the field of stroke, as we are dealing with it. And that was regarding that. So, which now usual question is, which is the most powerful risk factor of stroke? Powerful risk factor of the stroke. Okay. I launched the poll. You can try answering it. Not keeping track of the time. Polls are consuming some time and the flow is getting interrupted, but it's okay. You practice by answering, giving the answers to the MCQs. I'm happy that more people are attempting, but numbers have reduced from the first MCQ. Please try answering the question. Then only you will come to the groove of solving the MCQs. So you think it's a prior stroke, but more than that, it's actually the advancing age, which is the most powerful risk factor for stroke. This is a direct wording I took from, I think, Harrison. And next question will be, you need to be aware of few studies, especially while you are trying to crack the institute exams. So this would be this question, Sparkle trial. What do you think was dealing with in case of stroke? Yes, you have, most of them have correct, answered it correctly. Actually, it's actually dyslipidemia which was it was dealing with, and it emphasizes the fact that high dose statins are need of the hour to reduce the stroke reduction, stroke risk. And if you see, these are the studies. I haven't just gone out and took studies from outside. It's just the studies given in Harrison and some in Bradley. So Sparkle trial was actually dealing with statins, especially atorvastatin, and high dose statin was found to be useful in this study. And some studies like studies on pravastatin are there, simvastatin, and progress study dealt with perindopril and indapamide. And this is actually hypertension study, and this is about a study on stroke and the probands, maybe and the siblings especially. So these are studies which I took from your textbook. And next question is these kind of questions, rather than the direct questions, some one-word questions would be asked, like true or false kind of questions would be asked. So I'm not going into the polls. Which of the following is a false statement? Actually, the false statement here is that the intima is actually single layer of smooth muscles, which helps in inhibition of coagulation and thrombosis. That is why your blood vessels doesn't get clogged. And you may wrongly think that this is the right answer, but actually intracranial arteries lack the external elastic lamina. And usually the arteries are 3-layered only. So what is the importance of this question? Because I thought this question would be asked just because of the reason that if you see, external elastic lamina actually forms the extracranial, is present only in the extracranial artery and absent in the intracranial artery. The importance is that is one of the reasons why there is more intracranial aneurysms rather than extracranial aneurysms in patients. Like, because slight shear stress or slight dissection like thing will produce an aneurysm, that is the outpoaching from the artery. That is an outpoaching which occurs, and it can further cause subarachnoid hemorrhage due to bleeding of the rupture of these arteries. And now This is a straightforward question from the text. What is the normal cerebral blood flow in the adult brain? Normal cerebral blood flow in the adult brain. This question we dealt with, question 19. So, what do you think is the answer? If you studied the textbook, you are sure to get the answer. Guessing would be a difficult thing for this. You can rule out the last option because it is a very small number and you are sure that this couldn't be the answer, but you will be confused with the first and the second option. So the answer is actually taken from Harrison, this question. And this question has been asked recently, I think in Jibmer, a similar question was asked. So this actually, most have answered it right. And the answer is actually 50 to 55 ml of ml per 100 milligram per minute. So the normal blood flow is actually 50 to 55. And as you know, if the blood flow reduces to less than 18, the limit, this is actually the threshold of electrical failure. So once the electrical activity doesn't occur, the functionality is lost. So you get hemiplegia even if the blood flow goes below 18. And complete loss of the membrane, that is all the ATP and all are lost, and the cell is about to die if there is this membrane failure, which occurs below 8 ml. So these are two numbers which you have to remember, because these are numbers which will be constantly asked, because these are numbers which we need to see, especially while trying to treat the patient with a stroke. Because we have the latest cerebral perfusion studies which look at the cerebral blood volume, cerebral perfusion pressure, etc. And these numbers are very important because of that. And that is the clinical. So clinically, the examiner who is setting the question will be prone to think that this question is important when they see the Harrison textbook or Bradley textbook. But you may think that these numbers are not necessary. And so next question similarly would be, I'll launch the poll. So what do you think the answer would be? Please try to answer this. So ischemic penumbra, you must have heard by now that ischemic penumbra is very important. This is the area of mesenteric perfusion, which we plan to save in every stroke patient with the recent thrombolysis, the thrombectomy, and increase the thrombectomy time to about 24 hours with the latest DAWN and the Diffuse 3 trial, is based on saving this mesenteric perfusion area, otherwise called as penumbra. So this is actually functionally silent, as we said, because of the electrical silence which is occurring. And what do you think is this area represented? Actually, this is an area represented by this, actually 8 to 18. So as you said, as this is a thrombus which is occluding the artery, and this area has already undergone infarction. Sorry. And this area has already undergone infarction. Let me restart. Okay, it's okay. So this is the area which has already undergone infarction, and this is the area which we tell as the penumbra region, the area with mesenteric perfusion. And as you know, this surrounding area is beyond the penumbra is the area of oligemia. And this penumbra and oligemic region are maintained. It is yet to get affected because of this collateral flow. This collateral flow may be due to a nearby branch or maybe due to the leptomeningeal vessels. And as you know, this is, so what we were talking was that this is actually the core, and this is the penumbra we are talking. But initially, in the acute stage, this core will be small and the penumbra will be large. And by the time, as time increases, time goes on, the penumbra is encroached by the core. And by about 24 hours, if there is adequate collaterals, by about 24 hours, the core is completely surrounding the penumbra, and there is no tissue which can be salvaged. So based on this study of penumbra collateral circulation, we have come up with the fact that usual previous window period was 3 hours initially. We extended it to 4.5 for thrombolysis, and for thrombectomy it was 6 hours, extended to 8. Then now it is then with the diffuse 3 to 16 hours, and now with the latest Dawn trial, it is increased to about 24 hours. So that is the importance of penumbra and blood flow in the region. And a CT brain of a patient, this is CT brain of a patient who presented with right side weakness. So this, as you see, this was the initial CT which was taken, and then after 10 days, the CT was repeated. You cannot find anything wrong in the CT. So what do you think it is happening to the patient? Patient completely recovered, or is something happening in this patient? So I'm sure you have seen the CT. My question would be, was it actually cerebritis occurring in the patient? Or is the CT actually not the original CT? It's not belongs to the same person. And was the CT dates misplaced or misnumbered? Or was it an edema which has now reduced? Or the answer is none of them. Okay, I'll tell you that this patient didn't have cerebritis because we didn't give any antibiotics to this patient. And definitely we cross-checked for any patient with a CT brain when the dates were taken, because it could be easily, it can easily mislead you. Because an initial CT when a patient comes with acute ischemic stroke would be perfectly normal before the early signs of CT set in. And also it is not the same patient CT. An edema if which had of a lesion which has reduced, then the next CT should have shown some portion of the lesion as such. So the answer for this one is actually none of the above. Why? I'll tell you that. Before that, I'll just show you what are the early imaging features in CT, which is usually asked. So early imaging features is actually, this one is actually called the dense MCA sign. And what is this called? MCA dot sign. These two are different. MCA dense sign is actually due to the proximal MCA thrombus. M2, the segment in the sylvian region getting affected, produces the MCA dot sign. And this is the obscuration of the lendiform nucleus. This is because of the infarction. There is obscuration of the lendiform nucleus which is seen. That is, there is insular ribbon sign, absence of insular ribbon sign, because collateral flow is not reaching. Flow is not reaching here. And this area is getting affected early. That is insular ribbon sign getting affected. And this is actually effacement of sulci. You can see the sulci boundaries on the normal side, and the affected side, because of the edema, it has become effaced. And other one is actually the dense basilar artery sign occurring in posterior circulation. So I'll tell you one thing, that is dense MCA sign. It is actually due to the fresh thrombus. But in case of high hematocrit and calcification, we can actually have a false dense MCA sign. For example, one patient who was an alcoholic came to us, and he was having left-sided symptoms. But if you see the dense, his CT, we found that the patient was having MCA sign over the both sides. And we were wondered because he was having only left-sided symptoms, but MCA dense sign is present in the both sides. And this is just because of the reason that the patient was dehydrated and his hematocrit was high. As you know, he was a chronic alcoholic, and he had a binge of alcohol without taking water. And the problem with this is that being an alcoholic, he had developed seizures and he had developed Todd's palsy. So high hematocrit is actually can produce false dense MCA sign. Just a point to remember. And rest of them, I have just noted it down. So what happens in the CT is the normal, you measure the CT based on the Hounsfield unit. And the normal, it will be about 29. And when an infarct occurs, the hypodensity sets in. Actually, it sets in, it goes down up to 30. In chronic infarct, it will be around less than 20 Hounsfield unit. So what was happening in this patient? You saw that the initial CT was normal, and the later CT had near normalized. This doesn't mean that the patient had become normal. or the CT has corrected out. But some people may complain that you have wrongly treated the patient. It was not an actual stroke. You have missed something and all. So this is actually an artifact, just for your knowledge, that is called a CT fogging phenomenon. That is the transient return of the infracortical cortex to the normal, which occurs due to multiple reasons. And the best way to differentiate, if you are in a very high confusion, like somebody is so much arguing that this is not actually an infarct we have wrongly treated, you can easily do a CT contrast, which shows mild enhancement in the region. MRI definitely helps. And it does not represent any recovery, but it's just an infarct. So actually, I'll tell so if you go and try to buy a Puma shoes, and if you are not that careful, you may end up with even a coma shoes or a coma apparel. So that is regarding stroke mimics. The stroke mimics actually are things which trick us into thinking that it's a stroke. And as you know, stroke is an emergency, and a patient presenting to the casualty with the features of stroke, we don't have much time to rule out whether it's actual stroke or not. And I use the mnemonic usually vitamins, and the most important stroke mimic would be hypoglycemia you have to look out for. That is why in the AHA guidelines, only investigation you should do before going for thrombolysis in the AHA guidelines is to do an RBS of the patient. GRBS of the patient. Rest, even ECG, prop eye, other investigations like X-ray, etc. Apart from the CT, is just the RBS we have to see. Also, we have to make sure that the patient was not having seizures, because it could be just a Todd's palsy, and we think that we may thrombolyze the patient. So the important thing is that if such a stroke mimic comes to you within 4.5 hours, you are strongly sure it's a stroke, you have thrombolyzed the patient. Is it something wrong? Except for this bleeding, which will be evident in the CT. Most other things, the latest ASA guidelines, the AHA guidelines in 2018 say it is reasonable to thrombolyze the patient because they haven't found much of mortality or morbidity because the patient was thrombolyzed and it was a stroke. And I had even had patients who was referred as interesting case of stroke, a funny case of stroke, and it turned out to be GBS. And if you know that vestibular syndromes are notorious to present as like PPPV, etc., can even present as a posterior circulation stroke. And intoxication as in carbon monoxide poison. So that is regarding stroke mimics. The other diseases which mimic stroke. But there is another entity. What do you see here actually? I don't know whether you can make out. It's pretty clear because it is camouflage. You cannot see it properly. All chameleons are not green. So these are actually stroke chameleons. These are actual stroke, which trick you into thinking that is not actually stroke and it's something else. And the patient remains untreated even if he presents within the window period. For example, in case of bilateral thalamic stroke, as we have already discussed, artery of Percheron infarct can produce as a global amnesia. And sometimes limb shaking TA, that is, it will have a tonic-clonic movements that is due to a transient ischemic attack occurring, and it can be mistaken for a focal epilepsy. And also to know that cortical stroke, example, alcoholic coming with difficulty in lifting his wrist. You may think that it is actually a Saturday night palsy and the radial nerve involvement and all, but it could be even a stroke, cortical stroke in the hand knob area. That is small area within the cortex which get affected, results in the distal arm weakness. Also, bilateral occipital strokes results in confusion and delirium. This is actually other name for the balance syndrome which occurs, which causes much confusion. So recently one case was there, admitted in psychiatry for 1 week, and because of sudden onset of behavioral changes post-COVID. And we took an MRI and found out that there was a lesion in the Wernicke's area. So that is Wernicke's aphasia. The patient won't be understand anything and just will be talking out incomprehensible stuff and maybe branded as a psychiatric patient. So that is actually, these are the stroke chameleons, and it's important to differentiate. So what I have done till now is to give you how to approach the questions, how you have to read the textbook, some parts you have to emphasize, or I've tried to cover the stroke basics. Rest of the advanced part I will cover in the next portion. So before that, before finishing, I would like to tell you, like, discuss with you a few recently asked. So as you know, the recent NEET was over, multiple institute exams were over, and one of my students, Dr. Shiva Prakash, had helped me compile few questions, and and, uh, this was actually asked in the recent November aims. So which among the following is a CT based? You want to answer in poll? Okay, I'll keep the poll. But I think it's very difficult. Uh, I think it's very difficult to answer the poll, to keep the poll rolling with the lack of time. Uh, okay. Okay, let's see. So you can just answer the question. What do you think the answer is? Actually, the answer is aspect score. Yes, rightly someone has put in the chat box. Aspect score. So do you think aspects is only used for CT? As it's actually the Alberta stroke early CT scoring system, and less than 6 is actually a bad score. And now actually they have come up with the MRI based aspect score. So some institutions follow the CT protocol, some follow the MRI protocol, and in some difficult situation we have to go on with the MRI. We may need the MRI, and it's similar to CT. And in MRI protocol, we use the diffusion weighted imaging MRI for the MRI aspect grading. So this is actually the recent JIBMER question. That is the average blood supply to the gray matter of the brain is. So already we have discussed while emphasizing the importance of penumbra, that gray blood supply to the gray matter. Gray matter actually includes the neurons and the cell bodies, and they need the maximum supply. And we have discussed that it is roughly around 50. We have discussed that it was 50 to 55. Electrical silence point was 18, and complete absence was mechanical failure was actually 8, and in between we had the penumbra. And here we can see that it is actually 50, roughly 50. And you should know one thing, that is white matter doesn't need that much of blood supply as the gray matter, because gray matter has all the neurons or all the activity, ATP, all occurring mainly in the gray matter. So this question was the recent JIBMER question. One more question. You try to solve this question with the help of a rule of 4 by Gates. So in this question, if you see, the patient had sensory neural hearing loss, eighth nerve nucleus affection, 11th facial palsy, 7th bulbar and below affection, left facial hemisensory loss, hemianesthesia. So that is actually 5th nerve affection. So as you see, all these numbers are not divisors of 12, and these are not medial numbers, medial motor nucleus, just located laterally. So the lesion is in the side of the brainstem, and all these nucleus are within the pons. So this is actually a lateral pontine syndrome. And you know that sensory neural hearing loss is associated usually with the ICA. You don't, you shouldn't believe in thinking. You shouldn't be misled thinking that it's okay. This sensory neural hearing loss occurs only in ICA. It can also occur in superior cerebellar artery occlusion. Also, this is given in Brandley. And also, you should at this point of time, you should think of other neurological conditions which presents with hearing loss, etc. For example, Kennedy's disease, etc. So this question was asked in the NIMHANS previous session, not the recent one, the previous one. So the anatomical location of lesions causing prosopagnosia is. We discussed in prosopagnosia in large. So that was actually, if somebody remembers, it's actually Brodmann area 37. Actually, Brodmann area 37 corresponds to fusiform gyrus. Just revising, angular gyrus is 39. This Heschel gyrus would be 41 and 42. That is auditory. This corresponds with apraxia and alexia. Inferior frontal gyrus is the lower portion. It could include 44, 45. That is the Broca's area, and even 46. So That is the importance. And I think this is the last question, or maybe last. So, which is not an early CT sign of stroke? This is a comparatively easy question, which was asked in last enhance. Whether it's empty delta sign, sulcal effacement, loss of gray-white differentiation, or Sylvian dot sign. Sylvian dot sign is otherwise our MCA dot sign, which is occurring due to the M2 thromboembolism. Sulcal effacement we have described. Empty delta sign is actually seen in CVT. All must be aware. But most like such questions could be asked further. So that was regarding the topics, basics of stroke. Hope you had liked because there is a lack of, you cannot interact that much. So there is a problem. So hot topics of stroke will be coming in the next chapter, next episode, that is next module, where we will emphasize on investigations, thrombolysis, and thrombectomy. And please give a feedback to all this. And I urge you all to read these three starting from today before the next next module, because by the next module we will be putting a question answer session in the beginning itself so that you answer it. And I would like to have a feedback. Thank you. All feedbacks are welcome, because advices, ideas, etc. all will be welcome, because I want to improve this module better. This is my first time, so we'll just try to improve based on your feedbacks. You can send email or give this, give messages through WhatsApp and Telegram in this number. So hope you have benefited with this effort. And I thank Fine once again for giving me this opportunity for reaching the MD students who are preparing for the next NEET exam. So thank you all. Mansiji, are you here?
Yes, tell me.
So I think I finished what I was supposed to finish, what I have prepared.
All right. So we'll meet everybody again next Wednesday.
Okay. So we'll call it a day. Thank you everyone for coming. Next time, I think you should share this to other groups so that all are benefited. And thanks a lot. You can send me the queries in my number. Thank you. Thank you, Mansiji. Thank you, the Fine team, for supporting.
Yes. Thank you. Good night.